Okay. Good afternoon, everyone. Welcome to part one of Implementing Project Lazarus in North Carolina, Lessons Learned from the Project Lazarus Model. We will begin this part with a brief introduction and instructions from the wonderful people at the Child Safety Network. Thank you.
All right, thank you. So there are two options to hear today's audio. You can either listen through your computer speakers or call into our phone line at 866-835-7973. If you're participating via phone, please mute your computer speakers to eliminate any echo. Phone lines will be muted during the presentations to eliminate background noise. If you have any questions or technical issues, you can type those into the Q&A box on the lower left-hand side of the screen. There's also a PDF of the slides that's available for download right above that Q&A on the left side of the screen in the file share pod. You can submit your questions and comments at any time during this Q&A box. After the presentation, we'll pause for the presenters to answer all of your questions. This webinar will be recorded and archived and sent out to all registrants after the session. Back to you.
Thank you. The researchers at IPRIC, the Injury Prevention Research Center at the University of North Carolina, would like to welcome all of you. We begin this two-part webinar series with part one that focuses on the community-based or bottom-up components of the Project Lazarus model. The second part will focus on the clinical interventions, the top-down components of the model. Many of you left us questions on the clinical intervention strategies when you registered for this webinar. Be patient. We'll get to those during the Q&A section of the second webinar that will be broadcast on June 29th, also beginning at 2 o'clock Eastern Time like this one has. We'll discuss as many of your questions today as time permits. All questions and answers will be included in the forthcoming Lessons Learned white paper that will be released after the part two. Before we begin today, we'd like to say how grateful we are to the Child Safety Network, SAVOR, the Society for Advancement of Violence and Injury Research, and the South by Southwest Injury Network for hosting these webinars on the lessons we've learned from implementing Project Lazarus in North Carolina. And it goes without saying, we are also indebted to our sponsors, the Centers for Disease Control and Prevention, the Kate B. Reynolds Charitable Trust, the North Carolina Office of Rural Health and Community Care, and Community Care of North Carolina. But we'd be remiss if we didn't acknowledge that all presentations and discussions today reflect the views of the presenters and discussants, and do not necessarily reflect the official views of the Centers for Disease Control and Prevention, nor our other sources of funding. We'd like to begin by introducing Nora Farrell, the Director of Communications at the Kate B. Reynolds Charitable Trust. Nora?
Good afternoon, everyone. I'm Nora Farrell. I'm the Director of Communications at the Kate B. Reynolds Charitable Trust. Kay, thank you for the introduction and getting us started here. We are one of the largest private foundations in North Carolina and the largest funder of rural health and health care in our state. We're nearly 70 years old. We're a private foundation based out of Winston-Salem, but we fund all over North Carolina. We focus on improving the health and quality of life for financially disadvantaged residents. 75% of our annual grant making is focused on improving health around the state. As I said, we are specifically committed to rural communities, which is one of the reasons we were so interested in Project Lazarus. We invest millions of dollars each year in rural communities around the state to tackle issues including access to care, behavioral health, and diabetes, just to name a few. We know that prescription drug abuse is a huge issue in many of these rural areas, and Project Lazarus gave us an opportunity to tackle this serious problem. Prescription drug overdoses, as I don't have to tell many of you, have reached epidemic proportions, especially here in North Carolina. So when the Trust saw an opportunity to forge a public-private partnership to invest $2.6 million to combat the issue, we jumped on it. That investment allowed us to test a strategy that brings community coalitions, healthcare providers, and local government together, just to name a few of the partners involved. Specifically, we invested in Project Lazarus because we're interested in helping existing systems, such as the Community Care Network of North Carolina, the state pharmacy reporting function, and hospital emergency room departments become better aligned. As many of you know, Project Lazarus tested a community-based approach in Wilkes County here in North Carolina that showed fantastic results, and we wanted to see what that would look like if we took it statewide. The misuse of prescription drugs is a multiplayer community issue, and the communities that have done the best job tackling it have come together to solve it as a community, partnered, working together across multiple facets and engaging unlikely folks in the discussion. That's been the best way that people have tackled this in communities where it's working. Wilkes County also engaged an array of community members and residents in the problem solving, and we believe that's really key to success around the prescription drug abuse issue, but also around other issues that rural communities are tackling to improve their health. Project Lazarus's results in Wilkes County were stunning, including a drop in the overdose death rate of 69%, a reduction of substance abuse-related emergency department admissions of 15%, and more than 70% of Wilkes County prescribers registering with the state's Controlled Substances Drug Monitoring Program versus a statewide average of just 26% reporting. So that's why we were interested. We're really excited, and thank you for inviting us to introduce this webinar today. We hope that this great work will continue and that others will replicate and learn from what we're learning. I would now like to introduce Dr. Karen Mack from the CDC, who serves as the Science Advisor to the University of North Carolina Injury Prevention Research Center's evaluation of Project Lazarus. Dr. Mack?
Hello, good afternoon, everyone. First of all, I'd like to offer my thanks to all the staff involved in the CDC-funded project, the evaluation of a community-based initiative to prevent opioid overdose. And a special thanks to Chris Ringwalt and Kay Sanford for shepherding this two-part webinar through to fruition. As I expect you're aware, overdose deaths from prescription opioid pain relievers have quadrupled since 1999, killing more than 16,000 people in the U.S. in 2013. The purpose of this funding announcement that supported the work presented today was to encourage research to build the scientific base for the prevention of drug overdoses in the adolescent and adult population in the U.S. We had hoped to fund research that would expand and advance our understanding of approaches to prevent prescription drug overdoses. We sought to fund projects that would have the potential to yield high-impact results by reducing the public health burden and improving population health on a large scale. The two-year effectiveness study, which is the basis of this webinar, sought to test whether the statewide community-based initiative would, 1, increase providers' rates of registry and consultation with the state's prescription monitoring program, 2, improve access to substance abuse treatment by increasing the number of individuals who receive medically assisted treatment for opioid dependence, and 3, decrease drug-related morbidity and mortality rates attributed to opioid overdoses. CDC is conducting research to understand the circumstances and risk factors for overdose, and we are supporting states to ramp up their efforts in reducing overdoses. States are crucial players in reversing the epidemic, and a major new funding opportunity announced in March will provide state health departments with resources and support to advance comprehensive state law interventions for preventing prescription drug overdose, misuse, abuse, and overdose. We seek to give states the support and resources needed to build robust prevention programs. The March announcement had two strategies. First, to enhance and maximize state PDMPs, and second, to implement community or insurer health system interventions aimed at preventing prescription drug overdose and abuse. It had two optional strategies. One, to conduct policy evaluations and/or develop and implement rapid response projects. These strategies align with previous initiatives and build upon advances in the field. As we move from research to practice, it is important to understand the feedback loops necessary for creating efficiencies and achieving the greatest public health benefit. Articulating lessons learned is a principal component of continuous improvement. The important work highlighted in this webinar offers the opportunity for researchers and practitioners to consider lessons learned that can move the field of overdose prevention forward. And while a lesson learned can be simple as asking what worked well or what didn't work so well, I think you'll find the depth and breadth of knowledge gained in this project useful as a launching point for future work. Capturing And then articulating lessons learned is important for the field only if the information gained is used to improve programs that save lives. I'd like to thank you for joining the webinar today. The goals for the webinar are listed on the slide here. I hope that today's topic for lessons learned, that of public awareness and community education, community coalition building and action, coalition sustainability, and program assessment, evaluation, and data provide a rich base for discussion. And I'd like to invite you to tweet about the webinar. If you do, you can use the hashtag ProLaz, that's P-R-O-L-A-Z, for Project Lazarus. So again, hashtag P-R-O-L-A-Z. Now I'd like to introduce Dr. Ringwald, one of the senior scientists at the UNC IPRC, and he'll continue by describing the Project Lazarus model. Dr. Ringwald?
Thank you, Dr. Mack. The Project Lazarus model can best be conceptualized as a wheel with a hub and 7 spokes. The hub, which represents various community-based bottom-up activities, is our focus for today's webinar. The spokes, which largely represent top-down provider and institution-based activities, will be the subject of our second webinar on June 29th, and we do hope you will all come back for that. The model's hub contains 4 key strategies to the model. First, enhancing public awareness of the need for action. Second, the development of effective community-based coalitions to implement approaches to drug prevention that the coalition believes will meet the community's needs. Third, the use of data to demonstrate the nature of this need. And fourth, evaluation to determine the extent to which the actions and strategies adopted and implemented have actually been successful. In many cases, hub-related activities will also include one spoke, community education, designed to raise not only the public's awareness of and sensitivity to the problem of drug abuse, but to provide information on how community members can be actively engaged in addressing the problems caused by the misuse and abuse of prescription pain medication and other drugs. The spokes of the Project Lazarus model include an array of evidence-based, innovative, or best practices from which communities can choose. Some of these target medical providers, such as guidelines for appropriate prescribing and the importance of registering with and using our state's prescription drug monitoring program. Other spokes include changes to opioid prescription policies in hospital emergency departments. Additional spokes focus on preventing the diversion of prescription medications to individuals for whom they were not intended by means of such tactics as encouraging the proper disposal of these medications in secured drop boxes. Other spokes concern supporting patients with chronic pain by advocating and providing treatments other than prescription pain medication, and for those who may acquire a substance use disorder by promoting the availability and accessibility of community-based substance use disorder treatment. Finally, there are a variety of approaches to harm reduction that we will describe to you, the most dramatic of which is the administration of naloxone. This slide depicts the geographic breadth of North Carolina, home to almost 10 million residents. We knew the rollout of Project Lazarus from Wilkes County to the rest of the state would require some kind of formal infrastructure. We firmly believe that the hub components of the Project Lazarus model are best handled at the community level, primarily through county-based overdose prevention community coalitions. In contrast, the spoke components are needed to reach the state's medical care providers. No other entity in North Carolina reaches as many medical care providers and patients as the state's Medicaid Authority, Community Care of North Carolina, or CCNC. CCNC serves the state's Medicaid-eligible population of 1.4 million enrollees through 4,600 physicians grouped in over 1,600 primary care practices in 14 administrative networks, as illustrated on this map. Some of these networks include one county, several include over 20 counties. We knew from the outset that there would not be a one-size-fits-all approach. The strategies that worked in one CCNC network might not work at all in another. Nevertheless, we also felt that there would be lessons learned from each network that might help the others. So today's webinar begins that process. At this point, I'll pass the baton to the Reverend Fred Brayson, the CEO of Project Lazarus, who will lead off this brief but targeted presentation on the lessons that many of the Project Lazarus partners and stakeholders have learned in implementing and evaluating Project Lazarus by discussing public awareness and community education. Reverend Brayson, over to you.
Thank you very much, Dr. Ringwalt, and thank you all for attending today. And I'd also like to express our thanks to the Child Safety Network, SAVER, and South by Southwest, and of course, Dr. Frieden of the CDC, who are leading many efforts and their support to address prescription medication issues, but also those sponsors, those who have helped fund such a statewide project, KP Reynolds Trust and the North Carolina Office of Rural Health, working with us and all of the communities in North Carolina to bring about such an initiative that began at the grassroots, ground-up perspective, and now allowing us the opportunity to share our experiences and lessons learned. But none of this could have been accomplished, and I really need to thank all the individuals in all of our communities who have stepped forward to make a difference and to change and to save lives surrounding prescription medication and also other drug and sadly the heroin issues that are plaguing some of our local communities. As you can see, this is what Dr. Ringwalt was talking about, the hub and the spokes, and I'll be primarily focusing on the hub and talking about, public awareness, to the issue. And in 2004, when I began to see this problem as a hospice director with medication issues in the home among family members and friends, I realized early on that there was not a lot of awareness in the general community, that when I began to, sort of talk it up with individuals to find out some information, there was not a lot of knowledge, and that is what is, necessary for anybody to even grasp a situation and be an advocate, for change and dealing with a problem. But in talking with the individuals, we realized that, the stakeholders of the community is what, is necessary. And, if they're not aware, then there's not an action that's going to be taken. So it was necessary for a broad-based change to bring about, the strategies and the action plans. And we did that by presenting and teaching and training community sectors for, developing all of the different aspects of the strategies and those action plans. But to bring those before, the stakeholders was absolutely necessary, to have their buy-in. And as we learned early on in obtaining their buy-in, it was developed that we learned that these stakeholders as a steering committee, if we want to talk about a lesson learned, we got their acceptance and their buy-in, but if we're looking for them to be to take primarily the lead, stakeholders in a community are normally individuals that are extremely busy, leading organizations, leading agencies, leading efforts, and very much concerned for their community. But the one lesson learned was not to necessarily have them to do the leading, but bringing them forward to allow their buy-in, to have the presentation, provide them with the information so that they have the knowledge and the understanding, but to the point where, please give us 10 to 12 of your people from your agency, your organization, your friends, and your family so that we can work with them and build a coalition from the grassroots and what I call the community worker bees, the people that are living daily on the street, doing the work, going about their lives, but now being able to take actions in order to, address the issue. And that was a 2-year process back in 2004 and 5 and leading into 2006 in Wilkes County. And sadly, it was a negative that sort of connected the dots and brought the community together to where we had 3 overdoses occur, within a 48-hour period. And then it was on the radar screen. Then individuals were understanding. And then we were able to sort of move forward with a more cohesive, mobilized effort. But during that time, we were also looking at our data and trying to determine, what is actually occurring, within our communities. What is the reality? And that's when we started to work with the folks at our Division of Public Health Kay Sanford, the state epidemiologist at that time, and then drawing together with our Office of Chief Medical Examiner, our NC Tech data, which is our hospitalization and emergency department information, and of course, eventually our controlled substance reporting system, and then connecting with folks like at UNC, IPRIC, who had done other, health education and evaluation work, and just kind of pulling all of the players together that holds data. And of course, looking to the CDC for what data they were providing, which again gives us an overall view, a top-down view of what the global data is. But in order to drive at the local level, it's necessary that we bring forth the information for the individuals to know and realize what is happening within their community, so that they could understand from a local perspective what the issues are and understand that. Now, as we began to do that and build the public awareness, we came to the understanding ourselves that in talking with individuals and trying to understand why they weren't necessarily connecting, we realized that, there was the issues of, asking questions about, what is their connection? And so we started to ask questions about why am I needed, what do I need to know, and then what needs to be done. And in asking those questions, then they started to be able to see what part they could play, what could be done within their sphere of influence, in their, I call it their orbit of life, and realizing and pulling those stakeholders together, whether it was the schools, the law enforcement, the hospital, the medical care community, the public health, the mom and dads, the parents, the grandparents, the youth, bringing all of them together and answering those questions, why am I needed, what do I need to know, and what needs to be done, helps them to understand the role that they can play, whether a minimal amount or whether it's a maximum amount, but bringing that kind of education, and driving that, with the awareness. But proof of the need for this approach within a community is verified in this statement in slide 20. We hear people talk about doing something, but so far there isn't anyone who has really taken charge. And that's sort of where we were at that early time with many communities of, kind of aware of a problem, but, who's leading, who's doing what are the solutions? And it's very important to develop those solutions sector by sector, sometimes person by person, so that, again, they have that individual connecting. But also realizing that every community is different. There is no two that are alike. And you just saw a map of North Carolina, and you can go to the vacation lands to the east and visit the beaches and the communities over there that may have, in the wintertime, a population of 35,000, and then come summer with vacationers and so forth, they suddenly are up to 250,000. And then you can go to the far west mountains, which are also vacation land, and you have your Cherokee Indian Reservation, individual small rural mountain communities. They're all different, the populations, the cultures, their environments, and it's very, very important to allow a community to address who they are, how they are, and the response that they need to bring forward, and not just sort of say, here's your cookie, cut it this way, because that will not work with Project Lazarus. It has to be designed, flavored, and I call it colored to meet what is necessary within that individual community, because every single one is going to have its own prejudices, its own stigmas, its own beliefs, its own behaviors. And we know that in many of those factors that needs to change, because as soon as you raise awareness and they become knowledgeable of the problem, then of course those stigmas and behaviors and prejudices might start to play the blame game and point fingers, and we can't do that with this situation. We have to change what people think, what they know, and how they address, addiction and substance use disorder. And I learned that early on in Wilkes sort of the hard way, because when I brought up medication-assisted treatment, when I brought up the word, methadone as a treatment for substance use disorder, I was met with a brick wall. And I mean, not a pleasant one. It was not in my town, not in my neighborhood, not those people. And unfortunately, that was some of the stigmas that we were running across. But after 2 years of education and 2 years of working with the local community to bring the knowledge and understanding of what addiction is and the disease of addiction, we've been able to introduce, medication-assisted treatment, along with, of course, the promotion of all other aspects. And as many of you heard me say before, There isn't one treatment that works for everybody, but there is treatment for everybody, and we must have that within our community. Now we have the faith community supporting individuals in medication-assisted treatment. We have over 400 to 500 individuals receiving that treatment, and in bringing that about, we had a complete community change in that respect. And you can see from this slide that local methadone clinic helps reduce RX deaths. That was the headline of our newspaper some 6 years after a very negative, nasty meeting when we started talking about medication-assisted treatment. But again, we talk about all treatments being available. But then when you look at stakeholders in the state and others, it was our North Carolina Medical Board that stepped up very early on when we approached them with the situations that we were having in Wilkes and the problems, and asking them about, well, what about, the rescue medication, naloxone, and why isn't it, prevalently available, to anybody who's at risk? And they stepped up and said, we agree with that concept. We agree that naloxone should be available. And I believe if they were not, they were one of the first medical boards in the entire country that came out with a positive position statement saying, co-prescribing and making it available and having it available for individuals who are at risk, having it available for those coming out of jail or a corrections facility, having it at risk for those who are currently using and maybe suffering, overdoses and so forth, or having it to family members. So our medical board, I'm thankful for them for leading the way. So it's important to look at all the different players, all the different parts, and bringing them in, but all the different populations within your community, like our military community and our Cherokee Indian Reservation are ones we had to work individually with. And Fort Bragg, we started the Operation Opioid Safe there and worked with them on developing, buprenorphine programs within the Army base for active duty soldiers and their families. We worked on and were able to implement naloxone to those individuals who are at risk. And in that multifaceted approach, bringing in the medical community, the providers, the families, the sergeants, and the soldiers, we were able to reduce overdoses quickly within a 1-year time frame, considerably, within that Fort Bragg program. But again, working alongside them so that it was the right people talking to the right people, the medical docs at Womack Army Medical Center speaking to the other medical providers and those up their chain of command. And again, we learned the same thing at the Indian Reservation. Yes, I did go in and I did speak to the chief councils there at the Indian Reservation, but that was alongside their leadership. So as you get individual buy-in, that gives you the place in order to, to bring about change and helping every single population group, do what needs to be done, but giving them the solutions along the way and then having them design it in the right response for their individual community. So again, it takes individuals. I'm thankful for them. I'm thankful for our communities that are stepping up. I know that's happening around the country, and we share what we share today as lessons learned, but to present hope to you and to others that we can overcome what needs to be done and ensure that there is prevention, intervention, and treatment so that patients can receive, those who have issues can receive help and care with a warm handoff, and those that, could end up in a risk situation, that we prevent that from happening. So I thank you for your time today and appreciate that and look forward to any discussions and questions. And I'd like to now pass this off to Ann Thomas, who works as a regional consultant for the eastern area of North Carolina and handling the counties and the communities over there and assisting them in developing their response and their implementation of Project Lazarus. And now I turn this over to you, Ann. Thank you very much.
Thank you, Fred. After 20 years of local government service and working as the local public health director for Dare County, North Carolina, where substance abuse has been a long-standing priority health issue and where I led a community planning effort that successfully brought meaningful prevention, intervention, and treatment services to the community, I'm currently working as consultant with CCNC's Project Lazarus project, and in this role I assist communities in eastern North Carolina establish and build capacity for coalitions to raise awareness and to take action to decrease prescription opioid misuse and to manage chronic pain effectively. These photos represent a snapshot of the rural nature, challenges, and diversity in eastern North Carolina, and this is the area in which I live and work and what I will be referencing in my discussion today. Eastern North Carolina is primarily rural, diverse, and underserved, covers a large geographic area, has a small population base, high poverty levels with limited economic opportunity, and pervasive and persistent health disparities. Each community is different in terms of infrastructure, politics, relationships, community engagement, and available resources. As a result, the portal of entry for forming a coalition is different in each of these communities, and finding one entity to establish the infrastructure statewide has not worked. Additionally, many eastern North Carolina communities often have the same people at the table for meetings, so it's important to find a coalition that currently meets and grow it, however necessary, to address overdose prevention. If no substance abuse coalition exists, consider a legislatively mandated committee or task force, as they often include key organizations and leaders, and it has worked well in a number of communities in eastern North Carolina. There are 85 county health departments serving all 100 counties that have local autonomy in North Carolina's decentralized public health system, so they're well poised to reach the entire population. Given that opioid drug misuse is a public health epidemic and that the mission of public health is to promote and protect the health of the community, a first step is to connect with local public health departments to learn if a coalition exists in their community, and if not, if they're willing and able to convene and facilitate such a coalition. Health departments in North Carolina are required to perform a comprehensive community health assessment every 3 to 4 years to identify health priorities and engage community partners and members to develop action plans to address these identified health issues. In fact, most health departments are skilled at and recognized for bringing the community together to collaboratively find solutions to their community health problems in much the same way that Project Lazarus works. The community health assessment also catalogs assets and resources in the community, so health departments are the logical place to learn what the substance abuse resources are and where the gaps exist. While prescription opioid misuse is a concern in all communities, limited time, resources, competing priorities, and emerging health issues often serve as barriers to focused attention and energy being given to this issue. By providing support for implementation, including funding, technical assistance, and other resources such as public awareness tools, policies, protocols, and community-based trainings, Project Lazarus makes the decision to engage an easier one. Additionally, finding a win-win with health departments has helped to engage them to be the convener, facilitator, and fiscal agent. For instance, in North Carolina, local health departments are required by the State Division of Public Health to implement evidence-based strategies or promising practices to address priority health issues identified in their community health assessment for Healthy North Carolina 2020 focus areas. In counties that have identified unintentional injuries from poisonings, of which opioid misuse is considered, implementing the Project Lazarus model helps health departments meet this requirement. In counties where health departments are unable or unwilling to establish a coalition, finding an existing coalition that has a good track record, credibility, and stakeholder engagement that can expand their mission and membership is key. While existing substance abuse coalitions make a logical choice, they often have a focused mission, such as addressing the issue of underage drinking, or target certain at-risk groups such as youth, often through implementation of programs and services. As such, they are seen as a community service agency rather than a community change agent. In order to implement Project Lazarus, they need to be willing to expand their mission and membership to have a positive impact on the entire community and to be a catalyst for community and social change. It's important to help them embrace and develop the skills to effectively meet their expanded role as catalysts and advocacy for policy, environmental, and system change. Both the Kate B. Reynolds Charitable Trust and North Carolina's Office of Rural Health and Community Care provide funding to expand Project Lazarus statewide for maximum impact. For example, in Wilkes County in 2008, 82% of prescriptions related to overdose were written in Wilkes County, and in 2011, that had decreased to 0% as a result of safe prescribing practices. However, people would travel to neighboring counties where they often received a prescription for opioids. Therefore, it is important to scale this effort statewide and even wider to prevent this from occurring. Of course, there needs to be support for those addicted and seeking drugs so that they can get the help they need, which is another focus of Project Lazarus. Up to $10,000 in grant funds are available to each community, as well as many other resources to support implementation of the Project Lazarus hubs and spokes. Regional consultants provide assistance in coalition capacity building, strategic planning, community-based and sector training, public awareness materials, policies, protocol templates, examples from other communities, as well as data to assist with planning and evaluation. This support and array of resources makes the decision to move forward easier for coalitions, especially those in underserved and under-resourced communities. Once a coalition agrees to engage, it is imperative to secure the buy-in and commitment of key decision makers to support the ongoing work of the coalition. It is also important to mobilize, engage, and empower the larger community for collective impact. To do this, we facilitate a key stakeholder meeting, followed 30 to 45 days later by a community forum where more people are invited to the table. This helps build awareness and interest across the wider community and sets the stage for strategic planning and capacity building for the coalition. This order is important. Limited attendance or lack of representation by some sectors is a common challenge in rural areas. Identifying coalition members with relationships with these sectors and connecting with them in between meetings has gotten them to the table. This is an essential step, especially when this sector is the partner needed to implement a spoke that the coalition has identified as necessary, such as is often the case with law enforcement and implementation of an naloxone for first responder program. Connecting them with their stakeholder colleague in other communities that have successfully implemented strategies has also been beneficial. While I mentioned this earlier, I feel it bears repeating. It is essential that all understand that the coalition is not being formed as another service agency or being convened to support the work of the agency that serves as facilitator and fiscal agent, but instead is serving as a catalyst and advocacy group for policy and social change by changing beliefs, behaviors, and perceptions, and by impacting change in rules, regulations, policies, and practices in their community. Engaging and sustaining key sectors over time requires there to be an understanding of the collective mission and how it supports the work of each organization. It is important that each stakeholder understands why they are needed and what they can do. Establishing a mission and goals for the coalition that are not specific to any organization or individual is recommended. Also, establishing a name for the coalition separate from any one organization increases a sense of commitment, buy-in, and ownership to a cause. Rural communities often have significant health challenges and limited capacity to address them. They typically have fewer resources, training opportunities, and support systems to begin and sustain a coalition. They have a greater need for training around policy, environmental, and system change, as they are often more comfortable with developing programs and services targeted at the individual. It is important to find strong leadership, people with passion and knowledge of the issue, with the ability to manage and coordinate efforts, and the knowledge of informal networks in the community and how they work. Identifying and engaging a community member that has been significantly impacted by prescription drug misuse can be a powerful motivator and provide purpose to their life's journey. In addition to a community concern, there's a personal mission that drives these people to action. There needs to be support for these persons throughout the process. For instance, in Dare County, a mother who lost her son to a preventable drug overdose helped serve as a change agent in the community for increasing resources available for substance misuse and addiction. And while telling her story was incredibly compelling and powerful, it was also very difficult for her at times. Communities are often unaware of the extent of the problem of opioid misuse and its impact. The availability of real-time data, including drug poisoning mortality rates, emergency department visits, and hospitalizations for medicine and drugs, and prescribing profiles, raise awareness which often moves people to response and action. Data help target areas in need of focus and help inform the planning process. In addition to planning and grant writing, this data is used to evaluate the effectiveness of selected intervention and to identify changing trends that may need attention. This allows the coalition to address the most pressing needs at any given time. CCNC's Project Lazarus project has partnered with UNC's Injury Prevention Research Center for this purpose. There's very little education on pain management in medical schools, yet providers are required to assess for pain and to treat it, and often do so by writing a prescription. Therefore, provider education is a critical component of Project Lazarus. Linking the provider community is often difficult given the timing of meetings and their availability. The Governor's Institute on Substance Abuse and CCNC Network's Chronic Pain Initiative coordinators have been invaluable in engaging the provider community in CME trainings, both face-to-face and via webinar. These trainings have helped in changing practice patterns on safe opioid prescribing and effective chronic pain management. Now I'd like to turn you over to Jenny Irwin, the Director of the Drug-Free Community for a Safe and Drug-Free Cherokee County and an ongoing partner with Project Lazarus. Jenny is going to discuss some of the lessons she's learned about sustaining community coalitions from her perspective working in the western part of the state. Jenny?
Thank you. My role is lead in implementing Project Lazarus in our county. Since partnering with Project Lazarus, our coalition has seen success in decreasing the unintentional prescription opioid poisoning deaths by 93% in 2012, a decrease of 60% for the unintentional poisoning hospitalizations. The Project Lazarus partnership has provided us with the tools, funding, and assistance in implementing a variety of environmental strategies focusing on chronic care efforts. To sustain our efforts, purposeful recruitment of members to take leadership's role is the key. Identifying and engaging members of the community who have shown leadership skills in other ways is helpful to sustaining our efforts. Now, this does not mean that these individuals will necessarily take leadership of the project, but their presence, participation, and influence naturally encourage others to get involved and become invested in the prevention efforts. This also does not mean that the individual will remain in the leadership position for eternity. We have found it healthy for leadership roles to change periodically and last for short amounts of time for one project goal at a time. Setting up subcommittees for the projects so the volunteers know that there is a start and an end time where they do not feel overwhelmed or get burnt out. So, for example, our coalition purposefully recruited the Director of EMS Services to assist us in training EMS and law enforcement regarding carrying naloxone. The director met with, participated, and assigned a liaison from the fire department to work with the leaders to develop policy and training for the county EMS and fire employees. His leadership in promoting this training was instrumental in getting this policy and implementation process going. Another strategy for maintaining leadership is acknowledgement personally and publicly. This can be done easily and at no cost. Now, this strategy may seem frivolous, but we have seen that when we have provided acknowledgement to these individuals, they have been more willing to take on other projects where they have been hesitant in the past. Now, maintaining funding. We have found success in other agency grants. Now, that doesn't necessarily mean writing the grants yourself, but making yourself known and what you can offer for other agencies, finding you valuable so they will place you in their grant. Like, for example, the coalition partnered with the Sheriff's Office when they were writing a prescription drug prevention grant for the Governor's Crime Commission. The coalition agreed to assist the Sheriff's Office in the media portion and the community engagement portion and was written into that grant. Our coalition goal and the Sheriff's Office grant goal, we met the same criteria, therefore saving the coalition money for other budget items. Another example is the Health Department included the coalition in their mini grant proposal for prescription drug awareness efforts for media. This again freed up money the coalition had already allocated for prescription media to be used in other areas. Now, what happens when there is no money? Many communities put in a lot of time and work towards prevention to see it all come to an end because of loss of funds. So the question is really, how do we institutionalize our efforts? As I've said before, developing partnerships is extremely important, not only for funding possibilities, but also to sustain the work and continuation of the desired outcomes. Focusing on environmental strategies that also meet the needs of other agencies will sustain the work coalitions accomplish. For example, as our coalition began working towards decreasing the prescription overdoses, we saw the benefit in updating the ER prescribing policy utilizing the Project Lazarus toolkits. These toolkits are designed to assist medical professionals in updating their prescription drug policies by giving examples of prescribing practices that have been successful in other emergency rooms. We first needed to develop a partnership with the CEO of the hospital to assist us in bringing other medical professionals to the table. Project Lazarus assisted us in this process by providing a free educational training, including local prescription drug overdose data and possible solutions. Soon after this training, the ER adopted a prescription pain management policy. The purpose, to institute a practice policy regarding the administration of and prescriptions for narcotics and sedatives. The hospital CEO will continue to promote the use of the toolkits to other medical professionals to establish the same type of policy. This is an example of institutionalizing efforts with no funding and sustaining the overdose prevention work. Other examples include developing partnerships with local law enforcement, establishing 24/7 medication boxes, which will continue to serve the community as funding goes away. We developed a partnership with the schools by identifying how they can utilize the data gathering tool provided by the coalition for their school improvement plan. The school has agreed to add the data tool into their budget, again institutionalizing the coalition efforts. We are currently working with the schools again to develop and implement a naloxone policy, which will include training bus drivers and school personnel on how to identify the signs of an overdose and proper administration of naloxone. The schools have agreed to have naloxone available on the buses and in each middle and high school. These are types of strategies that are going to sustain prevention efforts even when our funding is not available. So now I'd like to introduce you to Nab Dasgupta, a pharmacoepidemiologist, co-founder of Project Lazarus, consultant epidemiologist at the UNC Injury Prevention Research Center, and chief data scientist and co-founder of Epidemico. He will talk to us about lessons learned from gathering and distributing data and program evaluation for the rollout of Project Lazarus in North Carolina.
Hi, Jenny. Thanks for that. So my job is to tell you a little bit about the data and how we're evaluating these programs quantitatively. So I'd like to think of things in terms of outcome and dependent variables. So in essence, we're trying to see if the interventions have led to changes in rates of things we actually care about, like overdose or opioid prescribing. In epidemiology, we call this outcome data, but others may call it the dependent variable. The first thing we did was to look for existing data sources with statewide coverage. All states have vital statistics divisions that collect mortality data. Of all the outcomes, to be honest, this is the one that tugs the heartstrings and the bottom line for many funders. One big issue, though, is power. Thankfully, the numbers of overdose deaths are not high enough where we would get to the county level to be able to do much statistically. But that is a problem on the epi side. So we chose to analyze these data aggregate for the state since it was a statewide rollout, which is not ideal, but that's what we had to do. The lack of complete medical histories also means that the data are kind of a black box, and the medical examiner practice may be idiosyncratic, for lack of a nicer word. In North Carolina, we've spent a considerable effort helping medical examiners standardize their coding practices for overdose. The data that we received from the State Health Department are coded in ICD-10, which jumbles together different opioids and heroin, making it difficult, for example, to specifically identify deaths from fentanyl-tainted heroin because there isn't a separate category for something like that. So this is an important data source. And you can find this type of information starting at the national level, going down to the county level at the CDC's Wonder website, which is a great resource. So the next data set we looked at, or data source, was hospital data. Hospital data are becoming more rapidly and readily available as electronic medical record systems are required to show public health applications and known as meaningful use. Many of these systems were set up as syndromic surveillance systems for infectious diseases and bioterrorism events, but we can repurpose them for overdose surveillance, and these data can provide a very rapid and clinically verified source of outcome data. Visits can be tracked down to the hour and minute of admission, providing a level of timeliness that's pretty amazing. However, we've seen quite a bit of variation between hospitals and how they code overdose visits. So using these data require a bit of standardization and on the ground and understanding what the biases are. The coding is ICD-9 currently, which has limited specificity for opioids similar to ICD-10. Finally, it's important to remember that these data cannot be used to calculate prevalence or incidence because access to healthcare is not uniform, nor are the motivations for seeking care. In addition, electronic health records and insurance claims data may be useful as well, but we didn't have ready access to any of those for this analysis. In North Carolina, we have a statewide emergency department monitoring system called NC Detect. Data from drug treatment centers is also a perennial favorite source of information on illicit drug use. A great level of detail is often available, including how much injection there is, what drugs are being taken, social outcomes like crime. But the major limitation of these data, similar to hospital data, is a lack of a denominator. So treatment seeking for drug abuse problems varies greatly, and these biases lead us to not be able to interpret calculations as incidence or prevalence rates. So put another way, do we see an increase in substance abuse treatment enrollees as a negative indicator of drug spread or a positive indicator for a widely undertreated disorder gaining more clinical use? So another tool that is in a lot of states now, almost all states except for Missouri, I think, is prescription monitoring program data. So PMPs are statewide electronic databases used at the point of care to look up patient histories for controlled substances. The data are generated when an outpatient pharmacy uploads records for a dispensed controlled substance prescription. So the data are quite inclusive and very detailed drug information. But the data sets themselves are huge and needs to be cleaned and analyzed using cloud computing resources. It takes considerable effort to format them for analysis, but we are happy to share our code and experiences with others to give you guys a head start. But there is a lot of privacy protections and data use agreements that need to go into place, and it's really the personal connection and statewide kind of initiative which gave us purchase to these data or access to these data. The data are a bit limited because because there's no diagnosis information. So a central question in this field is cancer versus non-cancer pain, and we can't differentiate that. So to date, I'm not aware of any state which allows for all 4 of these data sources to be linked by name. We've done some studies with name linkage on pairs of these 4 data sources, but for the most part, we're stuck with looking at them individually. So what we're doing is we're choosing to aggregate to the smallest sensical geographical unit, namely the county. So finally, the other really important piece of this is what I'm calling contextual data, my catch-all phrase. So this is information on potential confounders and exploratory variables. These are aggregate data at the county or census level, and if you're trying to analyze your data by county, you can use the area resource file, HRSA, census data. There are with Johnson Foundation community health rankings. There's a lot of other data which gives you information on potential confounders, substance use, alcohol use, things like that. So I also want to mention poison center data and EMS data, which are available in many states, including North Carolina. Those data were noisy and we didn't have ready access to them, but they're worth considering elsewhere. So on the next slide, the real question, that we had to collect data on was how do we know how much of an intervention has been done, where and when? And how do we know when the intervention was complete? So these are very difficult questions that generally require some creativity. The more centralized intervention is, the easier it is to collect data. The groups responsible for interventions and trainings often have process logs that record the number of attendees or the amount of pills collected at a take-back event. However, these data are primarily collected for grant reporting, which uses a potential bias of over-reporting, not surprisingly. So we took a series of approaches to get around this. We used an online form to collect survey data from targeted stakeholders. For example, once a year, we ask every local health director in the state to tell us about the climate and readiness for drug abuse prevention programming in their counties. We use a 6-item 9-point scale for this purpose that has been developed elsewhere. We need to do this assessment because the intervention implementation was not randomized, but rather reflected the demands of the funders while giving preference to early adopters. The data will be fed into a model as background information, allowing us to control for fundamental differences between communities and to mathematically put them on equal footing for the analysis using propensity scores or similar ways to handling channeling or confounding by indication. We are also collecting survey data from coalition leaders to understand how well the coalition is functioning and communicating. These questions are based on community coalition activation theory, which is a formal framework that looks at how much communication there is between groups and how well a coalition is functioning. So we can use this to quantify the strength of coalitions and how effective they are. But as many of the people who organize this webinar can attest to, getting full response to surveys requires a whole lot of follow-up and adds overhead and study personnel costs. So one final measure of intervention is worth mentioning, since it's kind of an innovative way to look at this. One of our goals was to increase the availability and utilization of drug treatment. So we can use enrollment data from drug treatment programs, like I mentioned before. But PMP data is also available for Suboxone, Subutex, and generic buprenorphine products, and might offer an alternative or supportive way of looking at the access to drug treatment. So I think there's potential there too. So if you go to the next slide, please. The next question in my mind is, how do we tie all these data together? The first thing to do is to find the smallest unit where we can get reliable information across all of the sources. Think of it as a lowest common denominator. In our case, we chose county month. While some data are at a more granular level, like hour of the day for ED visit, the month was the smallest unit of measure we could ask the coalitions to provide us in data surveys. Since the data are all in disparate time and geographic formats, we created a database we called the matrix. The data collected at smaller time units, such as days, we collapsed those into monthly counts. For example, by having access to line level or record level data, we were able to calculate the number of unique patients receiving opioid analgesics each month in each county. We have also more advanced measures, such as the number of unique patients getting overlapping benzodiazepine and opioid analgesic scripts, and the number of patients younger than 18 who are getting long-term opioid therapy. So we can use those as outcome measures as well. But it's important to have the line level PMT data in order to calculate those, because those aren't things that are going to be readily available directly from the PMT. So for data that are collected once a year or once a quarter, we have to do a little interpolation of the data to fill in the missing months. This is a model assumption, but it can be modeled as a step function as well. So we usually just do it as a linear trend, and that's fine for the way the models work. In general, we chose to assume linearity and connect the dots. So for geographic unit then, we chose to look at county of residence. By focusing on NC residents, we were able to calculate prevalence rate ratios, which are more straightforward to interpret than odds ratios, which is what we would have had to do if we included non-residents. Most data sources identify the county of residence, so that was pragmatic. And while we are limited to NC residents, we also look at the whole data set and sensitivity analyses to see if interstate migration had an impact on the findings. But this kind of allows the surveillance data to be translated into a more epidemiologic exposure outcome or dependent independent variable format. So the result is a large database, and this is a simple map with each row representing 1 month and 1 county. So a 5-year study would have 60 months, and since North Carolina has 100 counties, the matrix would then have 6,000 rows. And each column variable corresponds to one of the measures above, giving us nearly complete data for the whole state for the whole study period. We use Poisson and negative binomial models to estimate rates, and we can, using those, preserve the power of our sample size and also take into account repeated observations over time. The largest limitation is interlevel bias, also known as ecological bias. Our models assume that what happens at the county month level uniformly impacts every county resident. This is a common problem in surveillance studies and the same assumption as you make if you're comparing mortality rates for overdose between states. Therefore, the data needs to be interpreted carefully and couched in a way that acknowledges this assumption. In addition, where name and linkage is possible, we also conduct individual level studies of pairs of data to assess the impact of interlevel bias. Finally, going to lessons learned. Perhaps the most challenging thing has been requesting data use agreements and staying on top of all the requirements that each data provider has. It's tricky with one source, having a dozen is much worse. We are renewing data use agreements from some major data source nearly every other month. This requires maintaining strong relationships with the data providers. We have learned that keeping abreast of their methodological changes gives them confidence that you can use their data responsibly. This may include paying attention to funding decisions by the state legislator, personnel changes within health departments, and other kind of local politics, so to speak. Staff turnover at all levels has been a challenge. Even explaining this overall vision is difficult, let alone the details of data collection. At the end, we come back to the same question. How do we justify to the data holder or survey respondent why we are collecting this information? Part of the solution is to have simple documents that lay out the vision for data analysis and show how the pieces fit together. To be honest, we haven't been particularly good at doing this at all times, but the more we present the study setup, the clearer our message becomes. So I would suggest running your study design by wide types of audience and stakeholders at different levels of scientific aptitude. One key lesson we have learned is the need to meticulously record metadata. A code book is no longer sufficient. After trying many different approaches, in order to keep track of the matrix, we use a software that allows us to basically create secure message boards for each data source. for internal use within the project. This online space serves as a repository for everything from raw data to finished slides. Every change to the data is documented in chronological order, and people can go back and look at it even 5 years from now. We post our SAS and Stata code here as well, and we'd be happy to share any of that with any of the folks on the phone. So just to finish up, it's much easier to write the method section of doing it this way ahead of time than it is if you're trying to put a publication together. And so we add 3 to 5 sentences of text we can paste into a methods document in the methods section of a peer-reviewed document whenever we manipulate data and put them into the matrix. So I hope this overview has given you an idea of some of the ideas, have given you an overview of ideas for data you can use in your own setting. And please let us know if we can help. Now I'll turn you back over to Dr. Ringwalt, who will begin the discussion.
Thank you, Nad. That was a terrific overview. I do want to stress just how sensitive some of these data sources are that we are trying to get copies of. And the state maintains them, and other entities that are very concerned about any potential breach of confidentiality that makes everybody extremely nervous. So they want to make sure that the data that they give us are in a format that we will use them responsibly and not release any data in a way that could identify any particular individual. So we are very respectful of that, but it still requires a fair amount of back and forth. Now, we have several questions that have come in at various points. As Kay Sanford mentioned, we will reserve some of those for our second webinar upcoming next month. But we do have a few questions that have come in that are appropriate for our audience of our present audience, but particularly for the presenters today. There was a question that came in about something Dr. Mack said about the 16,000 deaths from prescription opioids was it in 2014 or 2013? And the answer is 2013. So whoever asked that, it's 16,000 deaths in 2013. So we have a question here that may be appropriate for either Ann or Fred. I'll let you tussle about that long distance. How long does this model take to fully implement in a community that has some of the components already in place? In other words, when you're partway there, how long does it take you to get all the way there? Ann or Fred, would you care to address this? And remember, you have to unmute yourself.
Yeah, I can answer that some, and Ann, please, chime in with any of your thoughts. To describe, the answer to that, even the state of North Carolina asked us, where do you begin? Do you look at the data and determine, sort of the worst of the worst counties and so forth in communities? And my answer was no. We begin where there's energy. And we learned early on that there's no wrong door. We're looking for community energy that can either develop or already be, community leadership in order to begin a coalition. And certainly no one, well, I should say no one, but we don't start with, all the spokes and the hub, all at once. It's where the energy is. If there's energy in the medical community to bring about something, then that's where we begin. So there's no time frame on, how long it takes, because some of the lessons learned, changes in leadership kind of stall things for a little bit. Where there's, extreme energy in 3 or 4 of the spokes, then, it takes maybe a while to build some of the others going forward. No two communities are alike, so I'm very hesitant to put a time frame on it, but we have started in some communities where we had one person with a passion and a desire and energy to do something, and they were the ones that could talk it up. And then we came alongside them to begin to build something, starting with one sector group at a time, and then it gained energy and implementation, from there. Now, it took us a long time in Wilkes because we started with nothing and had to even build awareness. Today, there's more awareness, so it's easier to bring about a mobilized community because they are, more aware of the problem, but the trick then is, so to speak, is to, start building solutions right away. When we tell a community, when somebody comes to us and says, we want to start something, I said, well, just at least start. That is your first step in whatever capacity that you can, and then work it from there. But if you've got a team, obviously, you can build it much quicker. So what took us now, myself personally, 11 years in Wilkes County addressing this issue, and of course now with other communities, you can probably do in 6 to 9 months. If I was going to kind of do any kind of a framework, in 6 to 9 months, you can have your 3 to 5 strong community sector relationships, commitment, and started working on and designing your solutions and your action plans. And those numbers pretty much hold to be true to at least have some element of implementation. And Ann, if you want to chime in.
Yeah, Chris, I think the question also was relating to communities that already have a coalition in place. Is that correct?
Yes.
Yes.
Yes, it is.
And my experience has been that in those communities where there's an existing coalition, it's much easier to get started because there's an organization that is aware of the issue, working on the issue. Oftentimes there's a staff person that can dedicate some time to it. But as far as rolling out all of Project Lazarus, it varies, as Fred said, how much time it takes to get all the folks to the table that need to be there to raise the awareness in the community. And it's dependent sometimes on what other grants the coalition may have and what they're working on. So I don't think there's a one-size-fits-all there either. But certainly I think they're better points to start.
Yeah, let me also add to that, Ann, now that you clarified, thank you, on existing coalitions. If it's been a single-focus coalition, say if it was only prevention, so to speak, you want to be able to bring in the different aspects that are necessary, the balance of prevention, intervention, and treatment, and that overall scope within every single community. As Ann shared in her part of the presentation, this isn't any one organization. It isn't any one just specific targeted scenario. It has to be balanced and brought forth across the board. Don't expect that day one. That's a building process.
Okay.
One of the things that I've encountered over the last several years is that when you have a new coalition or when you have a community coalition that is already up and going, one of the temptations we have is to try to steer the coalition into doing what we want to do, which begins to look more like a top-down approach. I'm from the government, you have a problem, and I know how to fix it kind of scenario, where what we want to continue to stress is that each community needs to identify the areas that resonate with the community residents. And then once those are implemented, then one can move on to other areas. So even if you do have a community coalition that's set up, you have to allow them to choose what they want to do and then strategically challenge them to broaden their horizons to include more of the hub and more of the spoke. And so, again, there is no one easy answer. It's a slow process in each community, and it has to fit the needs and the desires of the community.
Thanks, Kay. Nab, we have a couple of questions for you. One is, can we share a logic model of the study, which I think is a very good question. I'm not actually sure that we have one we can share, but we certainly should put, at this point, but we should certainly put one together. As I'm beginning to envisage it in my mind, at least, it's quite elaborate with arrows going in lots of directions. But Nab, do you want to try to answer that question, and then I have a second one for you?
Sure. I mean, we are happy to try to put one together. I think different studies have had different formats for logic models. We tend to use kind of the publication level inpatient inclusion exclusion type of a format, but we can try to provide something else. It would be helpful for whoever asked that question, if you could give us an example of one that you think the format is useful, and we can see about copying something along those lines.
Well, I'm not sure I know who asked it, but if you are still on the line, you might let us know. But Nav, the second question for you from Abby Tapper is, can you elaborate on your methods to make a non-codebook codebook? And exactly what software do you use, and how long does this take, and so forth? If you could talk a little bit about the process, I think that would be of use.
Sure thing. So the limitation that we felt with codebooks is that because the data that we are putting into the matrix comes from different sources, and some of those sources may be aggregating from other sources upstream, it was getting to be too cumbersome to have one place where all that information was summarized in a single file. And sometimes we would have to, because this is a multi-year project, we would have to add data when it came out for, in the following year from the same source, things like that. So what we do is we use a software called Basecamp, and it's a project management collaborative software, and it's like $15, $20 a month or something like that, pretty reasonable. And it basically creates a discussion board for each of our data streams. So just looking at it quickly, the one for the PMP, we may have over 100 emails that we would have sent to each other back and forth saying, I'm changing this or looking at this or how do I do this? But instead we have it in one unified place where we can, share the SAS code, data code, where we can put in all the metadata, and then at the end of each one of those kind of have a summary where we write out the methods in a format that can be cut and pasted into a peer-reviewed article, and we have all that metadata. Now, what we would do then is kind of archive all that information. So some of the discussions on there might be 2 years old, but at least you have every decision that was made, why it was made, who made it, when it was made in one place, and you can always have that to go back to. For practical purposes, the final matrix will have a simplified codebook that gives an overview of each variable. But for people who are really interested on how was this calculated, why does it look this way, this serves as a resource to always go back to. I hope that answers the question. And I'd be happy to share screen caps or kind of talk through more details if you're interested.
Thanks, Nab. We have a question for Anne and Jenny both. Please describe any public education and or outreach efforts that you all have been involved with. So again, this is for Anne and Jenny. Who would like to go first? And remember, you may be on mute.
Well, in my role as helping communities develop capacity, the education is initially around the what the Project Lazarus model is, using statistics to show what the burden of the problem in each community is, talking about the success in Wilkes County with implementation of the model, sharing examples from other communities that have worked. And then there are also a lot of public awareness materials that have been developed that are shared with community groups that they use in their communities. Jenny may have more specific community education that the coalition itself has put together, which is probably slightly different than what's used to engage and motivate and empower coalitions.
Yes, we've actually had a lot of community education around educating our medical professionals, which is a very interesting issue to work around their schedule and their timeliness. We've also outreached to our parent and community in terms of town halls and different parent education outreaches, just to encourage them to ask more questions of the medical professional in terms of naloxone and Project Lazarus. And those are the parent and medical professional awareness activities that we've engaged in.
And we also provide community education for coalitions depending on what they select to implement in their communities. And it can be naloxone training for first responders, A lot of training is about some of the laws that make it easier for people to seek help, like the Good Samaritan law in North Carolina, education about the Controlled System Drug Registry and the law change regarding that physicians can now delegate to someone in their office to really help people engage in activities that are going to help curb the epidemic. And then those folks bring it to their community in a variety of ways.
Well, thank you. Fred, do you want to add to this at all?
Yes, I do, because I want to point out something that Jenny and I, did in her Cherokee County. In order to, work with the hospital and the medical community and all the providers within that, in a hospital scenario, and law enforcement and their treatment folks, we actually did one whole day. We did a breakfast at the hospital, we did a lunch at the hospital, and we did a dinner at the hospital. And then people who were on those different shifts at those different times and from outside of the community were able to attend a breakfast, lunch, or dinner, and it was the same presentation all the way through, covering a whole lot of ground, a whole lot of territory, a whole lot of individuals meeting at their selected time frame and providing them all the information, regarding Project Lazarus, but also, some of the steps that they can take. That one day led to law enforcement getting on board with, the drop boxes, discussions about naloxone, and the hospital CEO becoming 100% on board. And within that next month, that's when their policies in their emergency departments were completely changed around in order to put in best practice and best prescribing policies.
Thank you, Fred. I'm going to take the moderator's privilege and ask a question of my own. You folk who are out in the field, Jenny and Ann and Fred, are there strategies that you think are being underutilized in the menu of options that you provide, which I envisage personally as a kind of cafeteria? Take what you need. But that you find yourself biding your time to saying, well, wait a minute, you're really not paying enough attention to this or that, and I wish you'd do some more of it. But you really can't say this because then it becomes an expert-driven model, not a community-driven model.
I guess I'll start. This is Fred again. The easiest elements of certain designed interventions and so forth were the tangible ones. Stepping up and doing the pill take-back days and putting in permanent drop boxes. When you had a tangible activity that gave you a tangible result from the asset that you did, there was a lot of energy behind that. And those are all good, and it creates public education, community awareness, and an action that almost anybody can do. But then when it got more into the changing of the concepts and misconceptions and preconceptions about addiction, substance use disorder, and having those discussions at every level of every age group, those are things that I find are lacking in every aspect, even in the medical community, mainly because I don't even know how to address that, or I don't know how to even approach that, or how do I talk to somebody about that? When I hear comments made that, why should we, and I'm sorry to have to say this, but I've heard it, why should we save their lives? That kind of scenario. So it's very important that your coalition and your steering committee become a speakers bureau, that they know how to talk, even if it's minimal, but they know what to say in as many aspects as they can as to who they may be talking to, because I use the influence of one person knows 12 people. And if that one person influences the 12, then those 12 can, each one of those has 12. And that's how, that's how it worked in Wilkes. And we've seen that in Cherokee and other counties. Those are the hard parts because it's not as tangible and you don't see that immediate effect all the time. But that's where it has to happen in our schools and our faith community, where it's more message-driven rather than a specific action-driven.
Thanks, Fred. Jenny and Ann, do you have anything to add to that?
Well, I agree with Fred. The whole issue around the stigma and addiction as a disease is something that needs more attention, in my opinion. I also think addiction treatment. And simply it's, how do we do this? Certainly these funds don't pay for treatment. Treatment is not available in many communities, and it's really hard to for communities to feel like they really can impact a change in that area. So that's another hub that we'd like to see more work in.
Well, thanks, Ann. Jenny, anything to add?
The only thing in this area, I know one issue we continue to get presented with is in regards to having communication. As Fred and Ann were talking about addiction, one question is, when we find out that we've assessed he's addicted, where do we send them to? The referral process is a constant question. And so therefore, we have less conversation going on. And our coalition encourages individuals to have conversation with their doctor, because I think that is a problem that we're having, is that if we do assess you are having issues with pain medication, but then what do we do from here? And that is one thing that we're encouraging.
What do you do next? I mean, to get someone to the point where they recognize there's a problem and then say, well, sorry, not much to be done, or wait 6 months, or whatever. Seems to me to be doing everybody an injustice. We have a question, Nab, that makes me feel a little awkward, so I will punt it to you, which basically has to do with when can people expect to see some of the first fruits of our evaluation, I think, in essence.
Sure, not awkward at all. We are proceeding according to a plan we drew up before we started the process and agreed on with CDC. So we will be wrapping up data collection, primary data collection at the end of the summer and starting analyses in August with first results, hopefully in September, October, and then moving on to preparing abstracts and papers for presentation in 2016. But we'd be happy to let people know what we're finding as soon as we have some kind of reliable analyses done.
Thank you, Nab. Let me see. I think that is just about all of our questions. There has been one about whether the work that we are doing here may be pertinent to Maryland. I'm not sure if the person who wrote this is on the line, but Fred, have you done any work in Maryland, and can ProLaz be fruitfully implemented up there?
In certain aspects, it has been up in Washington County, which is the Hagerstown area. I've worked with Mr. Bayer over at your behavioral health and others at the state level. Baltimore harm reduction has also been engaged, and I've received calls from numerous other counties, Montgomery County for one, and others, and we are available for those in Maryland, and it essentially takes a phone call, and we'll gladly respond in any capacity that we can. But yes, we have been there and continue to do so.
We have a very interesting and pointed question from one of our listeners. Where have we failed? And this is a question for anyone to jump in and respond to. Where have we failed? What have been our failures? Okay.
I'll take one stab to begin with, and I think this is something that anyone who's worked in public health will recognize. In North Carolina, a couple of years ago, we began to see a decrease in the number of people who are dying from fatal overdoses from pain medication. And a whole bunch of us were almost ready to pat ourselves on the back saying, good job. And then we looked at the rest of the data when we saw at the same time the number of people dying from heroin overdoses had increased 3 to 4 times during that same time period. So whereas the number of fatal overdoses from pain medication was and is decreasing, at the same time the number of people dying from heroin is increasing. And if you look at the overall number of fatal overdoses, the number remains consistent. There truly is no perceptible decrease. So the thing I think we have to be really careful about is following the data very closely all of the time, because if you look at data that are a year or two behind the times, you don't know what's really going on, and you can miss something very, very critical.
Well, I'm going to try to answer this question myself from my very personal perspective of a tenant who is just about to enter, thank God, a detox because he tried to kill himself on a couple of occasions with a lethal cocktail of various drugs, including opioids. And he goes to a local hospital, and he goes through detox. He's discharged to his family without any kind of plan to speak of. Nobody mentions in 2 visits to the emergency department and 2 detox spells of several days each at a neuropsychiatric ward. Nobody mentions naloxone. Nobody says to the family, you need to keep this drug on hand. This is how you administer it. These are the signs and symptoms, and so forth and so on. Nobody does this. We're moving very quickly in this state to getting naloxone into the hands of people who need it, who are the friends and family members of users, but we are not going quickly enough. Okay. That concludes the formal presentation for part 1 of this webinar. We suspect that you all have other questions or concerns about building the infrastructure in your own community to implement an overdose prevention program like Project Lazarus. If you haven't already submitted a question, chat boxes are available on your screen. It would be helpful if you could remember the slide number of or the name of the person speaking, but we will work around that if necessary. So our time is coming to a close. Our sincere appreciation to the Child Safety Network for having hosted today's seminar. CSN will be sending out an evaluation shortly, and we sure would appreciate your feedback. And it will also make available an audio tape of today's webinar on their website by the end of the week. Again, remember, if you're so inclined, you can tweet us about it at #ProLaz, P-R-O-L-A-Z, and we hope that all of you will join us for part 2 of the webinar that will focus on the lessons learned from implementing the many different types of intervention strategies that Project Lazarus has to offer its communities. The second 90-minute webinar will be broadcast on June 29 at the same time, 2 o'clock Eastern Standard Time. If you haven't already, you'll need to register again at the CSN website. Bye for now. Hope we will be talking to you at the end of June. Thanks so much.
I
Wait.
have a little bit to say. Up on your screen should be the evaluation website, because one of the things that we do, and we hope we do reasonably well, is program evaluation. We would be eternally grateful, or at least grateful today, if you would fill out the SurveyMonkey and let us know how we're doing and if you have any suggestions. As a reward for that, if you look over on the left-hand side of your screen, you will see that there is a PDF available of all of the slides that we've used today. We invite you to download them and use them as you'd like.
Thank you again, everybody. I'll talk to you in next month. Bye-bye.